Well, thank you very much for the invitation, and I've had the opportunity to speak to this group some time before. So this talk is actually very informal. You've gotten to hear from one of our stars, Dr. Riccardo Miceli, who, if you don't know, is probably one of the premier electromyographers, nerve conduction people on the West Coast, is one of the members of the editorial board of Muscle and Nerve, which is sort of the journal for the professionals in this area. This talk really is informal, and one of the things I wanted to do initially was a lot has changed in 6 years. I've been with this department a really long time, and there was a moment where really we needed to step forward. And in the last 5 or 6 years, I've hired 16 clinicians, 9 PhDs, and the department's changed a lot. We've actually brought several programs on board. And I thought before we'd talk a little bit about neuropathies, I might have the opportunity to just briefly talk to you about what's going on in neurology department itself. Many of you probably have friends and relatives where maybe it would be good to know what sort of is available now here in Sacramento. I'm at that stage, I can never tell if I want these glasses on or off at this point. It's, you know, I can't remember until I try to read something and I can't see it. Basically, as was said, we're very fortunate. Neurology, I've hired a bunch of very young, very talented clinicians from all over, and we actually now are considered. Try this one?
Yeah, it's on, I think.
Okay. We're now one of the top 2% of neurology programs in the United States. We're ranked about 24 out of, I think, something like 500. Oh, okay.
It is on.
Is it on? I'll try a little closer here. Basically, at the moment, we have several things going on. We have, for long-standing, a Center of Alzheimer's disease and dementia. It is actually ranked #1 in the nation now in extramural funding. Does a lot of epidemiological research in terms of looking for risk factors for Alzheimer's. Recently has been funded for total programs looking at kind of health and exercise to try to see if it can intervene with individuals with minimum cognitive impairment. We have a cerebral disease and stroke group. We have now 2 stroke neurologists, are recruiting a 3rd. We have a neurocritical care center now, so people coming in are shoppered in. We now have the ability to give, of course, in the emergency room, a clot buster called TPA, tissue plasminogen activator, as well as thrombectomies. The latest recommendations now is that up to 16 hours. So if somebody wakes up with a stroke, we have technology that lets us know if the clot has impaired brain perfusion, and we have 3 neurovascular radiologists that are available that if it's appropriate can remove the clot. The most recent data as of about 4 months ago indicates that in many cases that can improve outcomes significantly. We have deep brain stimulation that we use functional neurosurgeons that we partner with in neurology, where we can use stimulators in the brain to treat tremors for patients with Parkinson's and people with essential tremor. We have a level 4 epilepsy center here at the Med Center, which means that we basically now have the ability, we have a group of now, I just hired another one, so we've got basically 5 epileptologists. It runs 24/7. We're having a pediatric epileptologist join us in the spring, and we actually in September, and we just opened up a brand new pediatric EEG monitoring unit as well as an adult monitoring unit. We are the only facility really in Northern California that can offer EEG coverage 24/7. We have both a pediatric and an adult emergency rooms, and our pediatrics goes up right now to the age of 18. We all practice together, so actually when we do see patients, we're all in a collaborative room, so we basically share pediatric neurology knowledge with adult neurology. We have one of the best headache specialists on the West Coast, Mark Leonards, and we're building basically a headache center. Movement disorders, we have 5 movement disorder neurologists. Multiple sclerosis, we're bringing additional neurologists to that program. Myasthenia gravis with Dave Richman, we probably have the preeminent expert and researcher in myasthenia, probably again, actually in the United States as well as the West Coast. We do have neuroanatomy. One of the senior physicians, even more senior than I am, actually has written a book on neuroanatomy and teaches both the 1st and 2nd years to make sure that our medical students now have an integrated study of neurosciences. In neuromuscular, that will be what we're sort of talking about today. We have 2 neuropsychologists with 3 fellows and increasing activity both in neurology and neurosurgery. As I said, I've hired 3 pediatric neurologists. We now have 4. Basically, they cover expertise, everything from acute inpatient ICU to basically one of them is an experienced outpatient pediatric neurologist with more than 15 years experience, I guess 20. And we also have a sleep medicine program. We'll show you where all this is located. It's now in our new Midtown facility, where we have basically sleep studies that are going 24/7, 5 days a week, and polysomnography on the weekends. We'll talk a little bit more about our neurophysiology. That also runs during the day for patients with neuromuscular disorders. And we have a traumatic brain injury program that is increased with neurologists who are trained in traumatic brain and neurocritical care, who are in neurosurgery with joint appointments in neurology. At the Med Center now, we have, again, because we have residents and fellows, we're fortunate. We have physicians and RNs at the hospital 24/7, which I think is a big difference for taking care of individuals with complicated strokes or with difficult seizure disorders. As I mentioned, we have these monitoring units, and we now have a dedicated neurocritical care ICU, which is 10 beds to expand out to 15, which again are taken care of by people who are actually boarded in neurocritical care, so their expertise is in handling patients with neurocritical care. So it's been a busy 5 or 6 years, but I thought I might bring this up because this is kind of all new, and you might have friends or relatives where some of this is relevant. The neuromuscular faculty right now, we're in the process of expanding it. We mentioned Dave Richmond, who is really studying a new autoimmune disorder called MuSK, and has just been funded on that. David is actually, again, a senior neurologist who's had more than 40 years experience taking care of people with myasthenia gravis. Riccardo Maselli, who's an absolutely outstanding electromyographer, and we're bringing additional people on board, but when we get a very difficult case, Riccardo is sort of my go-to. I'm sort of hyped as neuromuscular. The truth of it is my expertise was really back at UCSF years ago. I cloned the gene for McArdle's disease and mapped it. It was the first human muscle disease that got mapped. And when I got here, the dean said, "Oh, you're an expert in neuromuscular disorders." And I said, "No, I'm a molecular biologist." He said, "Yes, you are. You're a neuromuscular person. Read books, basically." It was old school in those days. We didn't do fellowships. It was like, here, go get a 3-volume book and read it. So I actually, unfortunately, see less patients now because I'm pulled out a lot for all of this administrative stuff. When you finally get to a point where you know what you're doing, they give you another job. Pardon? Oh, sorry about that. Yeah, so I'm sort of, my access is a little bit more limited, unfortunately. I go to way too many meetings and volunteer to make dinner, so I feel like I've done something during the day. Josh Dionathan was one of our wonderful residents, and he's now on faculty. He's also expert in neuromuscular. We're training him to be another really star clinician like Mark Lennertz. And Zhe Zhang is coming in September, and she's a remarkable young woman, originally from China. Her father is actually a neurosurgeon in Beijing. Hunan, excuse me. Zhe Zhang actually has wonderful credentials. She really did her neurology at University of Florida. She did her neurophysiology at UCSF. She's currently an assistant professor at Baylor. So we couldn't do any better. And she's coming to basically take on some of the stuff that I do, and her expertise is really in neuromuscular. She's done a neuromuscular fellowship. She's boarded. She's expert again in EMG and nerve conductions. So that will be helpful. And we recognize that there's a lot of neuropathy. As I'll say in a moment, it actually exceeds the incidence of restless leg syndrome in the community, particularly in the age above 50. So we're actually have another recruitment out for yet another neuromuscular person to really expand it out. And again, because we have a facility where we can do 5 beds at a time running throughout the day at Midtown, and we have some facilities for children in the hospital, we really have the bandwidth. Our big problem now is I've hired more people than we have rooms to see patients. We've been busy. So this is where we are. This is actually the ranking of neurology programs in the United States based on extramural funding, and you can see we're now number 5 in the country, actually. U.S. World News and Report. I have problems with rankings with stuff like this. The only reason I would even cite World News and Report is they've shifted their metrics more towards patient quality and away from sort of reputation. It turns out that the hospital CEO looked at our patient care and it matches with the top three, which is Mayo, UCSF. The only reason we're not higher is basically we have young faculty and we have no reputation whatsoever, which is fine. That'll be their job. But at the moment, we're actually 26 out of about 500. So we really are about, within the United States, we're regarded, and at this point now, I get a lot of correspondence from other neurology chairs about what we do at UC Davis and what they do at Cleveland and what they do at Mayo. You can see we've gotten busier. The chair of neurosurgery who's just coming on board, Griff Harsh, is from Stanford, and actually Griff and I overlapped in our training back at UCSF. And Griff has an MBA, and he says he always likes charts where they go up and out to the right. So Midtown, basically, which is where we're at, is I don't know if I put a slide in here or not of Midtown. Midtown basically was designed for neurological patients. I was lucky enough to have some input into the design. It's available for wheelchair and walker. It has 17 rooms. On the second floor upstairs, it has neurophys by day and sleep by night. And basically, in its first year, we've not advertised it because we wanted just to get the thing settled. It was already up to seeing 100 to 150 patients a day. So in our first year, we saw over 12,000 patients. So we're a little frightened, actually. It just turns out, seriously, what we've discovered, and I kind of knew this, was that there's just a large need for care for neurological patients here in Northern California. And that we're getting patients from Nevada, and we're getting patients from Oregon, and we even get patients from Southern California, because it's easier to come up I-5 and see us. So we're sort of becoming, I think maybe 30 to 35% of our referrals are actually outside of Sacramento at this point. So this is a long-winded way of sort of saying, yes, we're growing, we still need to grow, we probably need infinite growth. That'll be for the next chair. And we apologize if sometimes there's a wait a little bit for getting to see us. We're trying. So, neuropathies. This is nothing that you don't already know, I'm sure. The prevalence is actually pretty high, and it increases with people over the age of 55 to maybe as much as 8% of the population. This is back in 1997. We know that there's well over probably 4 to 5 million individuals who have neuropathies, many of whom actually don't know they have them. If you think back to your prior generations, many of your grandparents and parents complained of their legs being cold. They blamed it on circulation. They would often really not want to walk. Their feet hurt. And a lot of those were not circulatory. A lot of those were neuropathies. And it plays a role because what I end up seeing is a lot of individuals who have late onset, but the neuropathy is genetic. We'll talk about that. Also, we're a little concerned right now with metabolic syndrome, with the increasing obesity, because we know that with metabolic syndrome and diabetes, there's an increased incidence of neuropathy. I apologize, this may or may not be a little bit too academic, but I found that at least with residents, it was important to kind of just show what's meant by a nerve. A lot of people think it's kind of a wire or a single strand that comes out of your spinal cord and hooks up to a muscle, and it doesn't do that. This is the spinal cord. These are the roots. This is the dorsal root, and this is the ventral root. And this is where all the stuff comes out of the spinal cord from specific regions, and they fuse to form a ganglion, the dorsal ganglion. The dorsal ganglion, and we have those basically throughout our spinal cord. Okay? And then sometimes you'll hear with Guillain-Barré and other things that the spinal fluid protein in the spinal fluid is elevated. The reason it's elevated is because it leaks right here where there's inflammatory cells, and it causes protein from the outside to get into the spinal fluid, and that's one of the hallmarks of Guillain-Barré. And sometimes when people have a chronic form of Guillain-Barré, like CIDP, this will heal up and the spinal fluid protein will come back down. And it's really the electrophysiology that lets us know that they've really had either Guillain-Barré or a variant of chronic Guillain-Barré, which we call sort of CIDP. Anyway, this thing forms. a nerve, and you'll notice that the nerve is, what we call a nerve, is made up of a whole bunch of peripheral nerves. It's like a coaxial cable, and the nerves are of different diameters. And the different diseases can affect the different nerves and types of nerves. And that's important for us to figure out in terms of figuring out the causes of what the neuropathy may be from. The reason I also bring this up is when you go onto the internet and try to look up the word neuropathy, you'll scare yourself because it includes everything. It's pretty much like saying sports utility vehicle and not distinguishing between any of the different brands. And maybe in a way it's a little bit worse. And so what happens, it's also hard because when you go to the chat sites, everybody may have different kinds of neuropathies, or the injuries were caused by different things, and people respond to different sorts of treatments. And it's also been a problem for clinical trials, and we'll explain that in a minute. So this is not a great picture, but I just wanted to show the different kinds of distributions. You'll have heard of trigeminal neuralgia. Has anybody here not heard of trigeminal neuralgia? Okay, trigeminal neuralgia is a damage, it's still a peripheral nerve, but it's the trigeminal nerve that comes out the brainstem, and people will get shocks of pain on their face, or severe pain that's there all the time. And they will come on in with basically, sometimes misdiagnosed as a headache, but it's really, for instance, they may eat, or cold air will set it off, or a number of things will trigger it, and it's just absolutely incapacitating types of pain. We basically have a kind of a way of dealing with this in neurology. We have certain medications that we can treat it with, some of which overlap with peripheral neuropathies. We also have neurosurgical approaches where we can basically decompress the nerve. We work in partnership with our neurosurgeons, and they basically can perform procedures. And we sometimes, if we have to, either do a decompression of the nerve or a stimulator. But the bottom line is this is one type where the actual pain is on the face, and these are just the distributions of the trigeminal nerve. Another thing we see is postherpetic neuralgia. And many of you are probably familiar with postherpetic neuralgia. These follow the distribution of nerve roots. Now, just for all of you, I myself have had my vaccine for herpes shingles. How many here of you have had your vaccine? Good. Let me explain what that vaccine will do. It will not prevent you from getting shingles again. That's not its point. Its real point is to prevent you from having postherpetic neuralgia. So it is not uncommon for people who've had the shingles vaccine to get subsequent outbreaks. I think my wife has had three or four. And the point of them is after the vaccine, it doesn't look the same. It looks different. It can, because of the vaccination, but its goal is really to prevent you from having a type of damage to that nerve that ends up with a postherpetic neuralgia. Yes? That's a great question. The old shingles vaccine really is the one that I'm referring to. The new shingles vaccine has a higher dose, and it's sort of there's a hope that it will be more effective. It's not so clear because, interestingly enough, although they give it to people over 60, I actually paid for it and decided I wanted it at 50. More than 50% of people get it below the age of 60, and so in fact, really the majority that I see are actually in younger people. And you're right, I think the problem we get into is as we get older, our immune system is less robust and we mount less of a robust immune response, which is one reason that they've increased the dose. It's a good question. And we'll have to see how this new one, if it does a better job of preventing it. Yeah. Oh, the first vaccine? That's a great question. You probably, honestly, if it were me, I'd do it. I would still get it. But I think that the data could argue that you already have an immune response and you might not need it. The problem we really have is we don't titer the response. And I guess the concern really is mostly that as we get older, see the vaccine won't, or even having shingles won't cure you of herpes. It doesn't go away. We have about 5 to 7 viruses that live in our body. Yeah. Sure, we can do that. So anyway, we can go back on some of this. Anyway, as we're going through some of this, these are just the different distributions of the different neuropathies that we see, okay? Why do we work these things up? The reason we work them up is because actually, this is what I was studying research in back a number of years ago. Peripheral nerves will remyelinate. So if you get a compression injury and you haven't cut the nerve, there is remyelination. It's slow, it's often incomplete. We can still tell when somebody feels perfectly normal that they've remyelinated, but you can remyelinate. The axons can regrow. They regrow better in younger people than older people. Sensory axons grow better back than motor neurons do, and they do best for peripheral neuropathy. Okay? The neuromuscular junctions can reestablish, and that was some of the research I was looking at, was where you could make the muscle regenerate. It has special stem cells called satellite cells that actually live with the muscles and grow back. The autonomic nervous system can't right now regenerate, but can be retrained. For those of you who've ever been in a hospital and, say, been in a bed for several weeks, you may notice that the nurse will get you up, swing your legs over the bed, you get lightheaded and say, I think I gotta lie down again, and then they do it to you again. What they're doing is retraining your autonomic nervous system. They call it dangles. And basically, a number of things we do with the autonomic nervous system is exercises and physiology things to retrain it. Systemic illnesses can be treated, and one of the things that I look for and referred about are people that have systemic disorders that basically sometimes they present as neurological problems, and fundamentally there's sort of a missed systemic disorder that has to be gotten. Maybe the best shot is to kind of hold questions to the end so we'll get through, and we can go back on some of these. This is obviously a large topic, but basically it's worthwhile getting these things figured out to figure out what causes them. A lot of the internists have gotten very adept at ordering the basic studies and know to do that, and to treat it symptomatically, and to identify coexisting medical conditions. So one of the things we do with neurology is we identify what nerve types are damaged. We identify the location and the causes of the weakness. We talk about different kinds of pain, just in the same way that there's lots of different ways to describe snow if you happen to be an Eskimo. It's very difficult in our culture. We don't really have lots of words to describe the pain, but we really try to get a handle on it because it gives us an idea of also where it's located. And the kinds of pain that you get from damage to the dorsal root ganglia or the posterior portion of the spinal cord is different than other kinds of nerve pain. Okay. We use obviously combinations of special drugs. We try to stay away from narcotics if at all possible. We use something called drug synergism, which means that if we use one drug by one mechanism and another drug by a separate mechanism, we can get an additive effect while minimizing side effects. It's called drug synergism. It's where 1 + 1 = 4. We basically try, as I said, acutely we may have to use narcotics. We try to be very careful in them. And the reason for that is we've learned over time that narcotics on chronic use are pro-inflammatory. And that for a lot of patients that I have who have been on fairly high doses of regular narcotics, even when they're not escalating them, a number of them really come back and say, you know, I feel a lot better now that we've kind of dialed off the Tylenol number 3, or we've dialed off some of this. It can be necessary occasionally, and there are obviously individuals that use it as for PRN breakthrough pain, but it does have its downsides, and I think there'll be some new breakthroughs coming through that will help in the future. The other point of this is, and this is, again, do not underestimate the importance of physical therapy and occupational therapy. I think when I was a younger physician, I wasn't as sure about it because the science is weaker than it is in other areas, but the improvements that I've seen in individuals, particularly with motor weakness and even with back pain, and that has been impressive. I myself do it. And so it really, there's a lot we don't understand. There's still a lot that's now becoming investigated at the cellular level. But if your physician recommends physical therapy, obviously it needs to be the right type, but don't minimize it. Let's do this. We're getting kind of to where we want to sort of just answer questions. I think the fundamental thing is this. When I ask our residents who are not neurologists, what percentage of neuropathies do they think are diabetes, they'll always say, oh, 70%. And if you go to an internist, they'll always say, well, it's got to be diabetes, right? Or it's diabetes, or you're pre-diabetic, or maybe it's diabetes. and the answer is no. It may be true that possibly 40% of neuropathies tend to be diabetic. Actually, I see very few of them because they're handled by internists. 70% can be diagnosed. Interestingly enough, probably 20 to 30% of them are genetic. So that a lot of them that I see, even where people are developing neuropathies in their 50s and 60s, they'll say, you know, my mom basically had something similar and she had feet that were shaped like mine, kind of high arched, narrow ankles, and gee, she started to complain about her feet as well. And when we do the electrical studies, it looks symmetric on both sides. It's not asymmetric. And we do the additional studies to make sure it's not an autoimmune neuropathy, and it's not. And then we have the choice of doing a genetic screen, and there's about 50 different genes. So at the time that I cloned the gene for McArdle's disease, there was only two forms of genetic neuropathies known, Charcot-Marie-Tooth type 1 and type 2. It's very simple. We now know that there's well over 50 genes, that they really can present anywhere from infancy to late onset. I've seen presentations of people in their 70s, where basically had we done the electrical studies, they would have been asymptomatic, but would have demonstrated the neuropathy probably in their 20s and 30s, but basically became symptomatic for one of two reasons. Either it was just some slow evolution of the disorder, or in some cases there was a secondary feature, and that's sometimes why you see neurologists. They might be developing diabetes on top of it. It turns out that their nightly cocktail is fine for their spouse, but not for them, given that they've got a genetic neuropathy that they didn't know about. Or sometimes the chemotherapy, which worked okay for other people, becomes really a problem for them because they didn't know they had this issue. Just a suggestion, when you go to look for treatments and stuff, a good place to look is the National Institute of Health and use the .nih. And we'll talk a little bit about it. Most of you probably here, because if you're interested in neuropathies, you've seen these drugs. These are drugs that have been recommended. These are drugs that neurologists use, everything from gabapentin to pregabalin, which is Lyrica, et cetera. And we have certain drugs that we use for certain treatments. Basically, and we'll go to this very last point, basically the problem you get into is twofold. One, in order for people to figure out whether a drug works for neuropathies, they had to pick a population that had a uniform cause or etiology, so they picked diabetes. So you'll find a lot of times that a drug was approved because it was good for diabetic neuropathy, and then your insurance company will say, I'm really sorry, you don't have diabetic neuropathy, we can't approve it. And the answer is mostly because they don't want to pay for it, if you really want to get into it, because the damage is the damage and the nerve, and the drugs do work. So it's unfortunate. It was really for experimental design. It wasn't to limit the use of the drug. I think the second thing that makes it difficult is because it's such a diverse etiologies for neuropathy, is that when they do clinical trials, a friend will say to you, you know, I had a focused light that was put on my feet. You know, there's some groups out there that have used different sort of colored laser frequencies, and they shine them on people's feet. And there is a very small population that have gotten better. But when they tried it as a clinical trial, it didn't work. And part of the problem, again, is that with these clinical trials, you have to have large enough numbers of cases. And so what happens is you'll get a lot of anecdotes. And I guess that's one reason I do recommend start with NIH.gov websites. Look at basically things that are neurological association, because there is a lot of stuff out there. Some of it's actually harmful. There's a substance that's out called Norexin that's got B vitamins in it. And a lot of people take B vitamins for neuropathy, not realizing that vitamin B6 at high levels can either cause a neuropathy or make a neuropathy worse. So you don't want to do that. You're better off if you can. If you need B12, you need B12. And the easiest way to get that is you measure the levels and then you take it sublingually, so it's absorbed. But I would stay away, if you can, from some of these more mixtures of herbal medications, just because there's a lot of stuff in them. We don't know all the things that are put in those things, and they are a mixture of different pharmacologic agents. It doesn't mean you can't use turmeric because it's got an anti-inflammatory component, et cetera, but just be careful what you do and how you research it, that's all.
Thank you very much for such a wonderful presentation, very generous presentation. And it is really a pleasure for me to be here this afternoon with members of the Western Neuropathy Association I think this is a wonderful association, and it's helping a lot of people. And I'm going to talk today about a controversial issue. Well, starting with a provocative question, the pseudoscan. And the question is this a final answer to the question of small fiber neuropathy? Is actually bringing a provocative subject in itself, the subject of small fiber neuropathy. So as a way of breaking the ice, I would like to know a little bit have some feedback from the audience in terms of what is your understanding about small fiber neuropathy. First of all, have you ever heard of small fiber neuropathy before coming here? And what is your understanding? So please don't feel embarrassed and just raise your hand and say, well, this is what you want to comment?
Oh, no, I don't know.
Oh, okay. All right, go ahead. So,
On that t-shirt, which I'm wearing, you have an illustration, and you have a long axon that comes from the back, the spine, and then you have a little unmyelinated, axon is myelinated, and then you have the little small fibers down at the end that are not myelinated. So I wear the illustration of what the small fiber neuropathy is. And if you buy one of our t-shirts, you can wear it too.
That's really wonderful. And any other comments from the audience? Okay, all right. I'm going to bring it to this lady that is a little bit far away. Okay. Too bad that we don't have a second device
I
here.
was just diagnosed last year with peripheral neuropathy. So I have no information about small fiber neuropathy or what even caused it. It happened and the doctors worked on finding the correct medication. So for me, this information about the small fiber neuropathy and what causes neuropathy is a brand new topic for me. So I have no information about what's being discussed here except when Sonia, the pharmacist, talked about the medication. So this is very informative for me, just being diagnosed last year.
Okay. Okay, thank you for your comments. There was somebody else here that wanted to make a comment here. Okay.
So after two doctors, two neurologists, I finally went to this other one who's somewhat of an expert. And he said, there's many kinds of neuropathies. He said that you have small fiber. He said it's not peripheral neuropathy, it is small fiber neuropathy. He said, and you're not going to die from it. And then he went on. Then he went on and he said that, your small fiber, he said, is different than peripheral neuropathy in that your muscles are not going to get weaker. Perhaps your he said you perhaps will have numbness in your legs. He said it very rarely goes up to your arms.
That's right.
And he told me I should go out and walk as much as I can.
Okay.
And then he said, and don't come and see me again because you don't have a serious neurological condition.
Okay. So does everyone agree with that, what the doctors say? Probably that I don't agree, right? If it is your disease and you got a problem, it's a problem. It's not really ignoring that really won't help, right? So, but what I'm seeing here, what I'm hearing is there's a lot of different views of what neuropathy, small fiber neuropathy is. And we have here a test that I'm introducing to you. And by the way, I don't have any conflict of interest, so I will not try to sell you a pseudo-scan system, okay? But at any rate, it is indeed a very provocative subject, small fiber neuropathy, because, as Marilyn pointed out, many doctors believe that that's not a real problem, that you're not going to die and it's not a serious problem, and then probably somebody else should take care of the problem. And so that is not really what I don't agree with that. So I don't have to introduce to this audience these symptoms, right? Loss of feeling, freezing, tingling sensation, vexing tingling sensation, sharp pain. Sometimes the minimal contact with the sheath of the bed will trigger tremendous amount of pain, okay? Burning sensation, numbness, etc. Okay, so this is really what small fiber neuropathy is. Some of the symptoms of small fiber neuropathy, although you can have this with large fiber neuropathy as well. And then the other thing that is really well exemplified here is that it's more prominent in distal part of the body, in the feet, right, in your hands. Very rare neuropathy will start in your hips or in your shoulders, okay? So the concept is that neuropathy is a problem that is produced by a problem in the nerves that is length dependent, okay? The larger, the longer the nerve, the more likely to be affected. So your symptoms will start in your feet, okay? Because it's a length dependent process. To our medical students, we teach them that it's also a process of dying back, a process that we call Wallerian degeneration, which means that if the nerve is affected distally, there is a process, a retrograde process that starts chewing the nerve back, okay? So the nerve is being degenerated in a back way, okay? And then somebody mentioned about the myelin and the axon, okay? So there are fibers, the large fibers they have an insulation that's called the myelin. Everyone knows that, right? The myelin is good because it allows the nerve to function in a way of transmitting impulses very fast, okay? The more myelin and the thicker the myelin is, the faster the nerve conducts, okay? And then when there is a problem in the myelin or in the axons, then you get this situation. You got a problem with the degeneration of the nerve, and the problem with the nerve, it could be many reasons for the problems in the nerve, okay? Maybe you have antibodies. You have a flu illness, and then a couple of weeks after, you develop antibodies against the virus that cross-react with the myelin, and you have a disease that's called Guillain-Barré syndrome. Everyone knows what Guillain-Barré syndrome is, right? It's the disease of the myelin. Or maybe you have it in your genes. The proteins that are needed there in order to construct the myelin, your genes carry mutations, and that's coming from your family, okay? Or maybe you had diabetes, okay? And the diabetes, I will show this because diabetes is one of the most common causes of neuropathy, okay? And what is the pathogenesis? What is the real cause? Why diabetes impact the function of the nerve? And the reason of that is that this is a normal nerve. The nerve needs vascular supply, okay? And the vascular supply in a normal situation comes from something that's called the vasa nervorum, which provides very tiny arteries that goes to the inner part of the nerves, okay? And supplies all the nutrients and vitamins and things that the nerve need in order to operate properly, okay? Now, if your sugar in your blood is continuously high because you have diabetes, the sugar in the blood, you have proteins. So the sugar and the protein, they get together, okay, and create like a gump, okay? And that gump gumps like a substance that is precluding a proper circulation in these very tiny arteries, okay? And so that really is producing an obstruction of the flow of blood and so the nerve is not receiving the proper nutrients, okay? And so then you have the pathogenesis of diabetes, which is one of the most common causes of neuropathy. So, and we have a wonderful test for nerve testing, okay? And I'm sure everyone here, I had the test of nerve conduction study, and probably everyone here in this room had a test of nerve conduction study, which is a great test because it can measure the signal from the nerves. If those signals are delayed, we can tell that there's a process with the myelin. The nerves maybe are not conducting fast enough, right? Or if the signal is very small, we may be thinking in terms of an axonal part of the nerve that is damaged, okay? Now, as Marilyn pointed out, maybe she had this test and the test was normal. And what was in the past, we say, well, you don't have a neuropathy, okay? But the patient will come and say, well, but I do have the symptoms, right? So it got to be an explanation for those patients that have normal nerve conduction velocities, still symptoms of neuropathy, okay? So here's what happened is that in the skin, there are very, very tiny nerves, okay? And those nerves are so small, they are not myelinated. They don't have the insulation, okay? They're very, very tiny, and they come from very important parts, like Meissner's corpuscles, which are mechanical type of receptors that allow us to feel the pressure and the touch, and Pacinian corpuscles also that give us all this information that we need that coming from the skin that let our brain to process this information that comes to us, okay? And so, but all of those are very tiny nerves that are coming from the skin or going to the hair or to the sweat glands, okay? So all of that can be damaged independently from the damage of the nerves, okay? And we call this small fiber neuropathy when this is affected. And going back to the process of the pathogenesis of diabetes, this obstruction of the arteries can affect the arteries that go to the skin, okay? So those very tiny arteries can be occluded and then affect the function of these nerves that are coming from receptors and control the normal operation of the sweat glands and the sebaceous glands, okay? So, small fiber neuropathy, by definition, is a type of peripheral neuropathy that occurs from damage of a small unmyelinated peripheral nerve fibers, okay? And it's really, in a way, is fortunate that we have now this term, but it's a little bit unfortunate as well that we are stuck with the term of small fiber neuropathy. In part, doctors, we don't like that term because it is difficult for us to make the diagnosis, because we really don't have any good test to say, well, indeed, you have a small fiber neuropathy. It also overlaps with diseases that we really don't understand. Diseases like fibromyalgia. I'm sure most of you might have heard about the term fibromyalgia, or reflex sympathetic dystrophy, or complex regional pain syndrome. Diseases for which we really do not have any pathogenic basis that we can easily, for us, demonstrate that the pathogenesis is there. And then most important, as I said, we really don't have a good test to demonstrate that. Then patients, in a way, they like it because now they have the term small fiber neuropathy, but the ultimate question is, well, what can we do about it? And most of the time, doctors will say, well, we cannot do much about it, right? So that is a vexing problem. Many times, the small fiber neuropathy results from diabetes. And then what is the answer? Well, control of the diet, control of the sugar, things that are really difficult, okay? And most of the times, the disease cannot be reverted, okay, cannot be corrected. So going back to the question of the doctors, how do we make the diagnosis of small fiber neuropathy? Well, there is a test that is called quantitative sensory testing, which is a test that we delivers certain amount of stimuli in the feet or in the hands, and then we ask the patient is he feeling the input or not, and then we'll kind of do a quantitation of what the patient is saying to us. But as you can see, that is a very subjective test, including pain or including touch sensation or many modalities of sensation. For instance, my grading of pain 8, for instance, would be different from Marilyn. Would be a 6 for her, and for somebody else would be 4 or 2. Okay, so there will be, when you're really depending on subjective elements, you cannot really be completely sure what is really, what is the real grading. So there is another test that is called intraepidermal nerve fiber density. Have you ever heard about that test? Anyone? Okay. So this is really a popular test, and is actually, I would say, is the gold standard for small fiber neuropathy. Because what it is we take a punch biopsy of the skin, and we look in the microscope for the small fibers, okay? So this is a really very objective test, and is a gold standard for making the diagnosis of small fiber neuropathy, okay? And although it's a gold standard, there are some problems with that test too, which I will cover in a second. Now, there is a way to go around the fact that, one test is very subjective, the other test is a little bit invasive because you need to do a skin biopsy. So one way that we have been doing for many, many years, more perhaps 50, 40 years, testing autonomic function. And what is autonomic? Autonomic functions are the part of the nerves that control things that are autonomic, that are not really controlled by our voluntary system, okay? Like sweating. Sweating is out of control. We sweat because our autonomic nervous system. Our heart beats independently of our feelings, of whatever we're thinking, okay? This is autonomic, okay? And so, as I pointed out to you, the nerves that supplies the sweat glands are very, very tiny nerves. So, if we can demonstrate by test of autonomic dysfunction, a malfunction of small fibers, then we can make the diagnosis of small fiber neuropathy. So that is the concept. So first of this test is the quantitative pseudomotor axon reflex test, which is a test that was developed in the Mayo Clinic about 40 years ago. And it really what it involves is putting a small chamber in the skin and forcing a substance, which is acetylcholine, and acetylcholine activates the sweat glands, and then through the other part of the chamber, circulating either air or nitrogen and looking at the humidity of the air that is passing through the chamber. So that's one way to do it. It's kind of a cumbersome. I have done this test many times. I used to do it when I was at the University of Chicago. But as I said, it's a little bit cumbersome to do it, a little bit messy because you need to put a substance on the skin. And so another test that you can do, so this is not really very popular. We're not doing here at the medical center. And there is another test that is called the sympathetic skin response. And the sympathetic skin response is to deliver certain amount of current to the skin and see what happened with the voltage of the skin. If the skin, the resistance of the skin is changing, the voltage is changing, okay? And we can measure with a machine that change of the voltage. In a way, it's the same principle of the lie detector, okay? So if you're lying, the principle of the lie detector is if you're lying, you will have a change of the resistance of the skin, okay? Why will happen? Well, because there is an emotional component when you're telling a lie, right? So that's the principle of the lie detector, And the lie detector measures the resistance of the skin, whereas here we measure the voltage, okay? One of the problems is that this sympathetic skin responses, you really cannot do a quantitation very easily. It also habituates, meaning that if you do the stimulation several times, eventually it disappears, right? So that's not really a very reliable test. And so we have moved about 2 or 3 years ago to the pseudoscan, okay? And I will introduce it to you, the pseudoscan. But before going that, I was just going to say a few words about the intradermal nerve fiber density, which is entitled or involves a punch biopsy, which you do it distally and proximally in the leg. And I had to tell you, I have done several of this, and really it's uncomfortable, it's painful. Although we put numbness there, not only that, it's kind of it's painful. It can potentially be complicated with infection, not very often, but that is always a possibility. Anytime that we break the skin, that can happen. And then that's what it shows. It shows, we can do special techniques to stain the nerves, and we can measure in the square millimeter, the amount of nerves that we see. And then that would be a case of a normal fiber density, another case of a diminished fiber density, okay? The problem with this is that sometimes you do this test and it comes back with the result of mild decrease of fiber density, and we don't know how to interpret mild decrease of the density. Is that truly neuropathic or is not? Is relevant to the patient or not? And then you're talking about an invasive test. So we're thinking about that perhaps the pseudoscan being a very fast test and a test that can be used as a surrogate of the skin biopsy would be an appropriate test for patients with symptoms of small fiber neuropathy. And here is the pseudoscan. This is how it looks like. It's a very small computer, as you can see. And then you can see these big plates. So you put your hands on the plates, and you stand up in the feet plates, okay? And you do that for 3 minutes, okay? And during the 3 minutes, one important thing, you don't have to move. If you move, it will alter the result, but you have to be standing still for 3 minutes. And what happened is that you will deliver the machine, the plates themselves will deliver a small amount of current, okay? And so since the skin is not conductive because we have the epidermis, right? The epidermis acts like a big capacitor. It really charges electrons, but the electrons don't go through, right? Small amount of electrons go through whatever pore is open in the skin. And the pore that is open in the skin is the sweat glands. And the sweat glands have chloride and sodium, electrolytes that conduct electricity. Okay, so depending on how good your sweat glands are, then the conductivity of the skin will increase. Okay, and so we can do quantitation of that. And so if your nerves, if you have good small nerves that are going to sweat glands, and then you have proper amount of chloride in the pore of the sweat gland, then your skin conduction will be good, okay? So you will be within the normal range in your feet and in your hands, okay? But if you have a small fiber neuropathy, either because you have diabetes or you have whatever is causing damage of small fibers, it will damage those very tiny nerves, and then the conduction, when you deliver the voltage of 4 volts in the skin, that will not go through, okay? The conduction of the skin is decreased, okay? And we can do quantitation of that, all right? So this is the principle of the test. And it sounds wonderful because it's very simple. It really doesn't it's really completely painless because you don't even feel the electricity going through your hands or your feet, okay? So we can just say, well, take this face value and say, well, this is a wonderful test. We will do it. And Although that's not the philosophy of university centers, right? We really need to test, we really need to collect our own data and to make sure this is really what we're saying that we're trying to accomplish is being accomplished by the system, okay? So we have collected, by now we have about 150 patients that had a pseudoscan. And the analysis was done in about 100 patients, 99 patients. The age, the mean age of the patient, 53 years old, 53.2. And this is a typical age of starting with a small fiber neuropathy, okay? Kind of late middle age, started with those symptoms, median age 55, but a wide range, because you can see patients starting with these symptoms very early in life, in children even. I have down, and in the youngest patient I have done a pseudoscan was 4 years old, a patient with diabetes. So, and here's what the data showed, a little bit more common in women than in men, okay, you know that too. And here's what the data shows. If you go and you have the test, chances are that it's going to be 1 out of 2 is going to be normal. In other words, 46 patients in whom we did the pseudoscan out of the 99 patients were normal. So about half of them, half of the patients were normal, okay? 24 patients were abnormal, both in feet and hands, okay? And then there were discordant findings, like abnormal only in the feet in 3 patients, and abnormal only in the hands in 7 patients. And discordant meaning that it was a normal maybe in one hand, but the other hand was okay, feet were okay, and so on and so forth. One thing that is odd already is this, the fact that it's more commonly abnormal in the hands than in the feet. And if you remember what I told you at the beginning of the talk, that normal neuropathy is length dependent. So you would expect the test, if it were length dependent, to be more common in the lower extremities, in the feet. Do you understand what I'm saying? So that's a little bit something that kind of triggered our curiosity, why this is more abnormal in the hands and not in the feet. So it doesn't really, the first thing is that we started to notice that this really doesn't follow the pattern that we see in neuropathy, clinically or by doing neuroconduction tests, okay? Now, and let's put it in a bar graph. So out of the 100, half of them were normal, okay? Abnormal, about 1/4 of the patients. Then abnormal in the feet, just only in 3. More than half, more than double of those abnormal in the hands, and kind of a discordant pattern in about the similar, almost about 20 patients. So that's the data. That's what the data showed. So let's concentrate in those who have, yeah, go ahead.
Were all the patients tested symptomatic?
Yes. Yes, I will cover that. All the patients have the symptoms that are referred in the first slide. Burning sensation, tingling sensation, that sort of thing. And there was no difference on those who have a normal or normal test. Okay, so we'll say that, yes?
Discordant means what? Inconsistent?
What's that?
Discordant.
No, discordant, the only thing that it means is that, as I said, we have maybe one hand that is abnormal, and then the other hand was normal, and the feet were normal or abnormal. And so we play very conservatively this and only report the test as abnormal if we see consistently both in hands and feet, okay? So discordant is a group that say, well, maybe or maybe not, okay? So let's concentrate on the group that the test was abnormal, okay? And the mean age was 63. So one thing that really is obvious, that this group of people were older, okay? So if you go back to the previous one, the mean was 53, okay, with a median of 55 Here the median was 67. So clearly 12 years older, okay? So what it means that as you're getting older, your chances to have an abnormal test increases. And that makes sense, right? Because as we are aging, our nerves are becoming less dense, right? So that really makes sense, okay? So that's one thing that was something that we saw. Then as in terms of the symptoms, there were numbness, tingling, burning, and asking your question. Those were the symptoms, but as I said, no difference between the group that was positive and the group that was negative. Now, fasciculation, muscle cramps, kind of symptoms are really non-specific. You wouldn't expect to find this to be abnormal. That was what the data show. Whole body paresthesias, and paresthesias mean numbness in the whole body, okay? Well, that's for one patient. And trunk paresthesias, yeah, no pattern. It could be the whole body, it could be the trunk, and also symptoms of syncope, okay, which makes sense because there's also, depending on the autonomic nervous system, our blood pressure, okay? So we have a sudden drop of our blood pressure. It makes sense it will correlate with abnormal autonomic nervous function. And as you know, and Parkinson's disease in one patient, and you might have heard some patients with severe Parkinson, they can have problems with controlling the blood pressure, controlling the postural, the blood pressure can drop very suddenly, okay? So they're telling us a patient with severe Parkinson's disease can have problems with the small fibers. So, and this is really the most important things that I would like to transmit to you, that out of the 24 patients in whom we found the test to be abnormal, 5 patients have diabetes, okay? Whereas only 5 patients from a total of 46 patients in the normal control have diabetes. So here's one point, is that your chances to have a normal test if you're diabetic increases double. It also makes sense, okay, totally sense. It makes sense that if you're old and if you have diabetes or pre-diabetes, just a little bit of the sugar increase in your blood, this test may be abnormal. Those are 2 factors that really make sense, okay? Now, one thing that is also surprising is that out of the abnormal, the nerve conduction, there was no correlation with the test of nerve conduction, the classical test of nerve conduction, right? 6 out of the 24 has an abnormal nerve conduction velocity test, whereas in the group that have normal pseudoscan test, the nerve conduction velocity was abnormal in half of them, okay? So abnormal nerve conduction velocity in a quarter of patients with abnormal pseudoscan versus abnormal nerve conduction velocities in patients that have normal pseudoscan. What it means that there is no really correlation, and the fact that your nerve conduction velocity is normal or abnormal doesn't in no way predict if you're going to have a normal or abnormal pseudoscan. And I'm going to skip that because those are tests, are scientific tests that shows the values of this test performed by, this is a group in the UK, that shows there was a very good correlation between the pseudoscan and symptoms of neuropathy. This is in 45 patients with type 1 diabetes. And not only they demonstrated there was a good correlation with the symptoms of neuropathy, but there was also with the symptoms of cardiac dysfunction. Because as I pointed out to you, the control of the heart depends also on the autonomic nervous system. And also they demonstrated correlation with symptoms and also correlation with symptoms of abnormal cardiac function. And this is another study. This was performed here in Iowa by Gordon Smith. I know this neurologist personally, and I know that this has come from a very solid group. And also showed again that there was a very good correlation with pseudoscan and symptoms of diabetes. And this is the bottom line. Pseudoscan is a promising diagnostic test for diabetic diabetic type and idiopathic type of peripheral neuropathy, distal peripheral neuropathy. And there was a good correlation with these other invasive tests, as I told you, the intradermal nerve fiber density test. However, there is a test that really is not, that was a more recent study from Michigan, Ann Arbor, that in fact showed no much correlation between the pseudoscan and symptoms of autonomic dysfunction like syncope, syncopal episodes, that sort of things, symptoms of cardiac dysfunction. And so this was performed in a group of patients that were relatively young and patients with diabetes type 1. And so in no way this single study that I show you here, that show no much correlation, it proved that this is not a test that is not effective. It's just simply, I just wanted to show you the two sides. Those are in favor, and those are the ones that didn't find much correlation. Okay, so, and here are the conclusions, okay? We can open then the discussion. The conclusion is pseudoscan is a fast and objective test of autonomic sympathetic pseudomotor function, okay? Why I'm saying that it's fast? Well, this is really a fact. It's a very fast, painless test we can perform in the laboratory, and really it's an effective test. In terms of, is an objective test? Well, I think this is based on the fact that it's more frequently abnormal in elderly people and in patients with diabetes. And there are two factors that are telling us, we know those factors by pathology, that those correlate with small fiber neuropathy, and that's what we found at the medical center, that it correlates with these two factors. The other thing that we found that there is little correlation with conventional electrodiagnostic tests. So if your doctor tells you that you have a normal nerve conduction velocity test, in no way he is ruling out small fiber neuropathy. And if he is to perform this test, in no way normal nerve conduction studies will predict what will be the result of the pseudoscan. And then also support the fact that at the beginning I told you that a neuropathy is a length-dependent process. Either myelin or not in the myelin on the axon is a length-dependent. The longer, the more chances to have a problem. Here is not length-dependent, okay? Here, the small fiber neuropathy, first of all, can start any place. Not necessarily, it's more common in the feet, but really can start, I've seen many patients starting with symptoms in the back or in the patch of the skin in the thorax or in the chest, okay? So the pattern could be very variable. And well, evidently, additional prospective studies are needed to validate the reliability of the test as an indicator of small fiber neuropathy.
So today, I'd like to thank Ben for the opportunity to come and talk about our research and give you an update on small molecule inhibitors of the soluble epoxide hydrolase in nociception, which I'm sure this crowd is familiar with. Already? Okay. Let me shout. Okay, so nociception, that's pain signaling. And neuropathy and neuropathic pain are, when that's going wrong. And what I want to try and given the last speaker, try and give you more of an overview of is what we do. What my talk will be about today is what we do preclinically to demonstrate when we get a new small molecule, how that actually transfers all the way to becoming a drug therapy and a therapy for chronic pain. We have to go through years, basically, just to give you the real story, years of research and development, a lot of money, a lot of safety studies, a lot of applications and trial with the FDA and other organizations. But we're really happy to present here and let you know and update you on the progress that we've made. We've been funded by the Blueprint NIH Blueprint program, which will drive this into phase 1 and 2 clinical studies. So this is decades worth of research. This is the latest portions that we have on the pain work. And just to give you these updates. So who in the room has a science background? Okay. The rest of you have to remind me to keep you all along. I put on a bunch of the science slides because that's kind of my portion of the research is actually, I'm the scientist that does the preclinical research on the small molecules in animal models of pain and provide the data on efficacy and the pharmacokinetics, like how it runs through the body, that provide the data that goes to the FDA to then get this approved for therapy, and then it's first used in the phase 1 clinical trial in humans. So with that, the first thing I like to start off with is my acknowledgments, because they often get kind of squashed at the end. But to Dr. Hammack, of course, who couldn't be here today, but he is the CEO of Mycosis, a company I also work for. And we are developing the SDH inhibitors, small molecule therapeutics for chronic diabetic neuropathy specifically. We're funded by a number of institutes from the NIH. Most importantly, as I mentioned, the Blueprint program, which is actually allowing us to go to phase 1 clinical trial and up to phase 2. So, the science part, all the chicken wire figures.
Voice is trailing off.
Okay, how's that? Thank you. Okay, so to give you a background on just where we are in using our small molecule is we are looking at lipids in the body, and our plasma membranes and all of the cells are made up of these lipids, and when we have an event like an injury or inflammation, then those are released, and they're acted on by enzymes. And I think a lot of people here might be familiar with the cyclooxygenase enzyme and inhibitors like Celebrex or NSAIDs like aspirin and ibuprofen that block that activity of cyclooxygenase. That blocks the prostaglandins and in not making that lipid mediator anymore, that's pain relieving. What we do is here in the middle, where there's other enzymes that then form epoxycosinotroic acids. Big name. I'm just going to say EATs, which is the EET there. These cytochrome P450 enzymes create this epoxygenated lipid mediator. Then our enzyme, the soluble epoxide hydrolase, breaks open into the vicinal dials down below, and those dials don't have any activity. So the biological activity that we're aiming at is that epoxide right here, and those lipid mediators that have been found in our next slide. When we inhibit that enzyme and increase these EATs, it's been shown to be antihypertensive, anti-inflammatory, and actually what I would say is analgesic, which is against pain. So that brings about another idea when you talk about these drugs, because I've already heard gabapentin mentioned in the crowd, but as we talk about diabetic neuropathy or neuropathic pain specifically, people will recognize that a lot of people have hypertension with diabetes. A lot of people have inflammation along with their pain syndromes, which then becomes a problem when we want to give drugs that you can't take with hypertension, like NSAIDs, right? So people can't have prolonged use of ibuprofen when they have hypertension. So these kind of things become problems. That also, if you consider that taking long-term aspirin will give you a GI ulcer, right? So we're looking at our technology being the way that the epoxycosinotroic acids work is that they actually are antihypertensive, like I mentioned, and they actually don't cause those kind of problems with what is known to be a prostacyclin ratio issue of blocking COX enzyme that gives GI erosion. So we have some very good technology here, and it is offering really good analgesia. That said, I'd like to start off with a history which is kind of humorous, which is the first time we put the inhibitors in an animal, we got this flat line. And it turns out that this flat line is part of what I'm talking about, which is really fantastic, which means that they don't have any activity if there's no pain on board. We put this molecule into a normal animal, and it did nothing. Fantastic. We put it into an animal that had pain, and we see dose-dependent analgesia. So this is an inflammatory model of pain where we inject lipopolysaccharide, which is basically the outer membrane of a bacteria, into the animal. and it gives them an inflammatory cascade that we then treat with the soluble epoxide hydrolase inhibitors. And as you can see from the vehicle being 0 there, up to 10 mg/kg of the SEHI, we're able to actually treat the inflammatory pain in these animals. Then, this is a little complicated slide, but then we wanted to look at other models of pain that did not have inflammation as a background to see how widely we were treating pain and not just inflammation. And when we looked at other types of neuropathic pain, we chose diabetic neuropathy because it's actually a pretty good preclinical model to use. And what we found when we gave the animals diabetic neuropathy and left it untreated and they developed neuropathic pain was that compared to these drugs that we've been mentioning today, like gabapentin and pregabalin, that our SEHI, and this is now, when this says lead, that's our lead IND candidate that the company is pursuing, that at 300 times lower, 30 times lower the dose, we got the same efficacy in the diabetic neuropathic pain model. And this is, of course, in rats. We do this preclinically, we do this in our laboratory. As I mentioned, the rats have diabetes, it goes untreated, they get diabetic neuropathic pain, and we test that with similar tests that you've probably encountered as humans, which is a von Frey, where they pick your foot, and they ask you to see if that's painful, and they'll do it in different spots. We actually do that with animals, but with animals we actually have an anesthesiometer that's attached to it that can measure the grams force that they can withstand before they'll take their own paw away. So they don't tell us, but they withdraw their paw when they're uncomfortable, and we know the difference in grams that they've been able to take. So that's kind of the background on that graph. Moreover, then we went to the gold standard model, which is a surgery model. So the diabetic neuropathic pain is our indication, and we've shown that in our model of the human indication that we're going after. But moreover is that people want to see it in a model where it's due to surgery and there's no metabolism at the background of it, so it doesn't depend on the glucose level of the animal or their liver functioning and those kind of parameters. So we did it in a surgery model. So we actually surgically give the animals neuropathic pain, chronic neuropathic pain, and we call this a chronic constriction injury. It's a well documented model from the 80s, and so it gets repeated, and it's the gold standard for preclinical work in drug therapies for chronic pain. And what we saw, again, is this is basically, if you look on the right, this is our dose escalation, and we see dose-dependent increases in the analgesia. So this is, just to orientate you to the graph, is that when there's a low baseline, that means that they're in pain. And then as we increase by giving increasing doses of the inhibitor, we see an increase in response. So we're getting dose-dependent analgesia in this model. And again, this is done with a similar von Frey test, which is actually checked milligrams of pressure that the animals can withstand. And so it's then, as we noted before, gabapentin, I think this crowd better than anybody knows the side effects and the problems with gabapentin. For us, working with clinicians, it's also really a problem post-surgically when they want to send people home that are a little unsteady, and they give them gabapentin for pain control, and it causes even more dizziness, and then they get falls and further injury. So it's become, that kind of clinical problem, as well as people that, it has aberrant side effects that when you take it chronically is really unpleasant. But what we did is try to describe the differences between, again, so these are both of our lead IND candidate and our backup compound that we're developing for the company. And we try to describe the side effects of those in relationship to gabapentin and pregabalin. And what you see is that, yes, we do have a road rod for a rodent, and it's like a little treadmill. And we check on whether or not they can perform, walking routinely over a certain amount of time without stumbling or falling. And as you can see with the gabapentin, as you would assume with the kind of dizziness that's reported in human patients, we see that in other mammals, and they're less likely to be able to perform to the maximum. We saw absolutely no change for, there's a little bit of, that's not a statistical change, but normal variance, but no changes for the use of the SEH inhibitors. Then we do to have a balance beam. It's called a balance beam. We look for foot slips that has actually a walkway. It's kind of like what we consider a catwalk for a rodent, a rat walk. And we look for foot slips, and actually another sign of dizziness is if the animal stops, and it can't continue. It's a sign that it's having some proprioception problems and it's not able to go further. And as you can see with gabapentin again, that's coming up. There's a lot of variability. So some animals perform a little better, but that's true for usually the human reports on using gabapentin. Some people are okay, some people are knocked out by it. So just as a indication that we're not seeing the kind of side effects and motor functioning scores that we are with the gabapentinoids. And then, as I mentioned, GI erosion. It's a huge problem with anybody taking NSAIDs long term. And what we're finding is really interesting because not only can we demonstrate, so diclofenac is an NSAID, kind of like indomethacin. It's not used in the United States too much because it does have some liver toxicity, so we don't see it too often used here, but it is used presently in Europe. But with diclofenac, this is a picture of your villi in the intestinal wall, and that's what erosion looks like, and that's what a GI ulcer looks like if you were to cross-section. So you can see that the NSAIDs are causing ulcer, and not only did SEHI not cause that problem, but they're actually able to treat the ulcer caused by NSAIDs. And let's not forget that they're actually anti-inflammatory. That's part of what's happening, is that, and they actually are homeostatic towards the production of prostaglandins. So to get into the idea of, I'm sure you all again are quite aware about the problems of what, and the former speaker actually spoke about too, is like, even in humans, you don't want to measure evoked responses when you have a neuropathic pain problem. So we deal with this in basic science as well, which is how can we test an animal without pushing its paw and seeing how much it reacts? If it's not a pain that relates to being pushed, right? It happens idiopathically, it happens spontaneously, or sometimes it's tonic. You're always in a state of pain. So one of the ways that we do this is we've borrowed from addiction research a rodent paradigm where we're going to train the animal to seek out something, but that what they're seeking out as a reward in this case is pain relief. So we have animals that are in pain, we give them pain relief, and that's contextually related, so we give them cues. Where they're going to get pain relief is always in this corner with this furry carpet and this window. And then they learn to say, okay, so if I want pain relief, I'm going to go to that room in that corner with that furry carpet and that window. To give the breakdown on that. And so we train them in this paradigm so that the animal is free to choose where to go. And it's not dependent on, them being poked with a stick or a rigid tip, filament or anything like that. And it's whether or not, they've been associating the pain relief with the environment where they've received it. And so this is just an outline of what the test looks like. So the nice carpet in the window is not quite the way it looks, but we can constrict them to an environment where they can really see and feel the difference of where they are. And then the most important part of this test that I like to remind people is that when we test them later, they're not under the influence of the drug. So we test them before without any drug, before we get started, and later without any drug, because what happens is with drugs like gabapentin and morphine and things like that is that there's a drug-induced state of mental, change. And as they are on drugs, they might act differently than when they're not on drugs. So one of the, and when you're testing paw withdrawals and those kind of tests that we saw earlier, you're always testing an animal that has a drug in its system. So if it has any of that change in behavior, it's hard to assess. So this is one of the strengths also. Not only can we do tonic pain, but we're looking at the animal's association with this without having it in them when we ask them, if you like. So when we look at that, and the way that we assess the response is that they're going to increase the time that they spend in the drug-paired chamber, where they got the relief. So in all of these scenarios, when you see the change in time, that means they spend all of their time where they got the drug, the pain relieving drug. Okay, so when we did this, gabapentin had a good response actually for diabetic neuropathy. We put it in diabetic neuropathic mice, and we let them choose where to be once they had received their training, and they did seek out the gabapentin, which, as you can see, forgive me, as you can see here. But what we also find is that they seek out the SEH inhibitor. In this case, it was a openly published compound, TUCB, but at 10 times lower dose. So we're seeing that we have really potent analgesia, and we're, like, as I mentioned formerly, we're not seeing the side effects that we see with gabapentin. So importantly, what we have to prove preclinically is that the drug's on board. So what we did was show, over the time of the training, of every day that we train them, we have enough compound on board where it's inhibiting the enzyme. And then also that we don't see any effect when we give that amount to an animal that doesn't have pain. So again, flatline means that we're not seeing that rewarding behavior in this paradigm that we would with an animal in pain. And just to show here that the target of inhibiting the SEH is really an important part about this. When we give we give the inhibitor to knockout mice. This is a mouse then that lacks the soluble epoxide hydrolase. We have this genetic mouse to use preclinically. And we say, okay, will it have any effect, if the target's there, if the target's not there, in a normal mouse, in a mouse without, without the enzyme present. And again, we just see no significant reaction to the inhibitors without pain present and no matter what type of mouse we use. And just to show that the mice are competent. So these knockout mice are able to respond to morphine just fine. Their reward system's intact. And this is also just to show, this is how the test is classically used, which is they're given morphine, they seek out the morphine. And this is just in a mouse without neuropathic pain, but also just the genetic knockout. Then to combine all of these ideas is to say that we have shown that the control mice don't respond, the SEH knockout mice do not respond, and that diabetic mice that have the target respond robustly to the SEH inhibitors. So these are all kind of the controls and all of the different ways that we have to demonstrate that we are targeting the SEH is responsible for the pain relief, and that we can see it in a number of different ways. And so, as you've noticed over the course of this, I've demonstrated that we showed in diabetic neuropathy, we've shown it in a surgery model, we've shown it in rats, we've shown it in mice. So we take all of these steps to demonstrate, because people are, how do you really know, and what can you show, and how broad is it, and what is the spectrum of this? So that said, the other thing that we've done is demonstrate that it's actually also the molecule that we're using. So the EC5026 is the IND candidate, and that also, if it just depends on the molecule, and that's the effect. It produces the analgesia in the diabetic neuropathic mice. One of the unique stories that we have, it was an opportunity, is that we have a vet school at UC Davis, and we have collaborations with veterinarians. And one of them works with equine laminitis. So if some of you may know the story, but the horses stand on their toes. They have one toe, and it goes as a bone into their hoof. And then the lamina is the skin around that bone. And as it becomes inflamed due to hard training or diabetes, it can be diet-induced, that inflamed lamina will make it so that they can't stand. When they can't stand, they can't eat properly. When they lay down, they become hypertensive. And so you can see up there that in about 70% of equine laminitis cases, they're fatal. They need to be euthanized. Once the tissue destruction gets pretty bad, the neuropathic pain is horrible. The tissue destruction can get pretty bad, and as it continues, then they'll be euthanized. So when our collaborating veterinarian had one of these animals that was going to be euthanized, he got approval to use the SEH inhibitors as a compassionate use last try for this horse. And as you can see, 3 hours post-treatment, the horse was able to stand up. We continued the treatment, and we were giving it a super low dose of 0.1 grams per kg by IV, but this is a horse, so we ran out of drug by 5 days. Yeah, consider the kicks. But you know, Hula Hala is alive today. She lives at the vet school. She's used to teach veterinarians, and basically, getting into such a large order, you know, mammal means that we think that we're going to be translating this technology to human. And
Is she
not only-
still on the medication?
no, she's not.
Okay, thank you.
So, yeah, that's a nice point to make, is that she's had no recurrent laminitis either. So it's important, there's several factors that go into recurring laminitis, making sure that the animal is not over-exercised afterwards and things like that, but on a normal routine, some animals will, per diet or genetics, but she did not. So type diet control, kind of like human diabetes, type diet control and not overtraining helps with that.
As a specific indication for human diabetic neuropathic pain, but it is actually a wide spectrum. If we consider the research, it's a wide spectrum inflammatory and neuropathic pain treating compound. They're importantly inactive in the absence of pain, which I've tried to demonstrate. And that's one of the things that excites me the most. As I see people that want to be, you know, getting back out there, driving, you know, going, if they have to be at work, and getting on with their lives, and not having any off-target effects that are, and not having any euphoria, you know, not having an addictive reward, those kind of things are pretty important. And then we just love to get out and talk to people because this is really a novel target. This would be a first-in-class drug. But that said, it's in a very well-known arm of biology, the arachidonic acid cascade. If you consider that, I think about 80% of all over-the-counter NSAIDs target cyclooxygenase or target this pathway. I mean, it's a huge amount. But the novel nature of targeting the SEH to just elevate our natural endogenous lipid mediators is something different. And then we've, just to update you, gone through the preclinical toxicity testing. So I can report that we've done our 28-day, we've done one 28-day dog study. We're getting our 7-day rat study done. And those are, what is required by the FDA are 2 species and doing safety testing. And once we're all completed with that, then we go into phase 1 clinical trial, which is dosing in man. And we're hoping to get there by the end of this year, if not early next year, depending on the blueprint and their progress with us. That said, thank you.